Bueno, estamos nosotros para la próxima sesión de Rayo contra Cáncer. Estamos muy agradecidos para todos que están para esta sesión. Nos queda esta sesión y la sesión del jueves que será dada también por Dr. Sandwall. Él va a revisar Quality Assurance en estos dos, vamos a concluir este curso. Entonces, con esto vamos a... Thank you, Dr. Sandwall, for the time that you're giving us to give these presentations on quality assurance. We have this session today and then the session on Thursday. And now these will actually be the last two sessions of the curriculum. And with that, I will pass the time over to you, Dr. Sandwall.
All right. Thank you, Ramsey. My name is Peter Sandwall. I am from Ohio, which is in the Midwest. This is a picture actually of La Paz in Bolivia, and I do work with Radiating Hope as well. I'm excited that Ben has invited me back to give another presentation. This presentation, I'm going to focus on treatment planning, and the concept of quality. We'll talk about that. So I think the initial conditions for anything is to see what the professional societies have to say. So being aware of what the different professional societies have published and being familiar with their documents. I think that it takes a long time and a lot of work to create a consensus document. And so those documents should be respected. Also realize that it's slow to produce one of those, and knowledge evolves after their publication. So keeping up with the current literature is also important. So that obviously being from the US, the AAPM is a big resource that I use a lot, but there are other ones. There are a lot of other professional societies besides these three that I just showed, the IEAE being an international organization. But all of them have important contributions, and looking at their documents is very helpful. So I'll talk about some of the knowledge points in treatment planning in terms of prescriptions and dose tolerances, but really gonna breeze past a lot of that and get into the quality aspects. So some of the initial conditions, obviously, you can't get a quality plan unless you have a quality model in your treatment planning system. And the garbage in, garbage out is a common statement in computer coding. So you put bad data in, you get bad data out. So it's really essential that you start your system, you commission your system appropriately. And with stereotactic, it's the small fields. And since this is the last of many presentations, I'm sure you've heard it many times before. So I'm just going to touch it again. I mean, the small field dosimetry, it's not to be taken lightly. And even as simple things as how you set your chamber up are important. And I think that this IEA document on the dosimetry of small fields is very well written. And there's actually new updates that Seifel Huck just published last month about correction factors for small field dosimetry. So that document is still evolving, and maintaining awareness of the latest research is helpful. I'm a big proponent of end-to-end testing. The proof is in the pudding. This, you don't know what it tastes like until you eat it. So you don't want to test on a patient. You don't want to know what the outcome is on a patient. So getting an anthropomorphic phantom or a phantom that's human-like and running it through the entire chain is very helpful. Obviously, this is a rando phantom where you can place film in there. There are other phantoms, and you can make your own phantom. A lot of people, sometimes what they'll do is they'll get a piece of meat from the grocery store, like a ham, and just put an ion chamber in there. Go ahead and CT scan it and treat it like a patient with the ion chamber in there. So you can be creative. You don't have to just use the very expensive phantoms, but the idea is to test your system from start to finish. So this is a little bit about what I'm going to talk about. This is kind of an outline. I'm going to talk about qualitative assessment. So things that you don't necessarily put a number on, but things that you need to look at. There are different delivery techniques. Stereotactic's been employed for a long time now, and the technology's evolved over the years. And, you know, everyone would like to do everything with the greatest and the best technology and have the top of the line everything. You know, we would all love to have beautiful true beams with 6-degree couches. But that doesn't mean that we need that for to deliver quality plans. That doesn't mean we need that to deliver quality treatments. You can still deliver a quality stereotactic plan with an older LINAC, with older technology. You just have to look at what's achievable and make that clinical decision if that's something that is going to benefit the patient. But we don't need the latest and the greatest to do good quality work. The other aspect, and this is the aspect that's going to be most of the conversation or the discussion, is the quantitative assessment. There are ways that you could put numbers to things, and those are metrics of plan quality, and something that I really like. I like metrics a lot, but each patient is an individual, and it's hard to distill the quality of their plan down to a number, but it's still very helpful to do so. And we'll talk about some of those numbers that you can use to track your center's quality and track quality over time. And another one, a big thing, and it's kind of embedded in all these things, is acknowledge the uncertainty. We've got to recognize that we can't measure everything that matters, and not everything that we can measure matters. So we have to acknowledge what we do and what we don't know, and we'll talk a little bit about some of those things, specifically buildup and penumbra. So these are some of the consensus statements that I feel are important, and you will have this presentation when we're done. You'll have it to download, and you can review it. Also, feel free to screen capture. I don't always give the presentations out ahead of time, just because then hopefully you're more engaged in the moment. But I do understand there's also a language barrier, and I apologize for not being able to speak Spanish. It's on my list. I'm using Duolingo, so hopefully we'll get there. But these are some good consensus statements. The RSS, the Radiosurgery Society, and the AAPM, they put out the MPPG, kind of the latest one on SRS and SBRT. And it should be noted that their guidelines vary a little bit from TG 101, which also vary a little bit from the Astro white paper, which also varies a little bit from the original AAPM report. And that's because these things evolve over time, and they're also a little fuzzy. So maybe the authors are working with one type of machine, and they've set their tolerances based on what's achievable with that type of machine. Ideally, they would respect all types of machines, but it's very clear that in the case of TG 142, for example, that's a very variant-centric report, and not all those values are easily achievable with an elected unit. So just understanding the different types of machines and the context of the report is helpful. I also really like this report from the Netherlands. So this is their Radiation Dosimetry Commission. It's a great report on process management and talks about some of the concepts that I'm also going to discuss. So clinical resources. There are lots of clinical trials all over the world. I'm just talking about RTOG or the NRG briefly, but there are lots of them. ROSEL, which was a European SBRT study, is also a great resource. But these clinical protocols that have large accruals of data and can actually give us an idea of what's important are worth reviewing And these protocols, they really kind of set the stage for how people practice. And there's a good reason for it, and I'll touch on it later. But adherence to protocols actually has been shown to improve outcomes. So looking at the different protocols, whether you're going to be working with lung, this 915 and 813 are very common references, or spine, or you're starting to look at stereotactic outside of the traditional locations. And I know bony metastasis are a hot new one. So these protocols are very helpful in defining how you're going to define your plan quality. Dose tolerances, we're still learning a lot about, what's too much and what we should pay attention to. We had to learn the hard way about the brachial plexus, which is what I'm highlighting in this corner. There's a great Seminars in Radiation Oncology, or Green Journal, that's just focused on stereotactic dose tolerances. And one of the things that they did, which I think is worth noting and appreciating, is they didn't just give the TD55 or the tolerance dose for 5% in 5 years. They gave a probability. So they gave some awareness that you can push the dose, but when you push that dose, you're going to increase the probability of a normal tissue complication. And it should be weighted. That probability should be weighted with the need to control that tumor. So they take a different approach. It's not just a one number that you do your best to stay below, but it's a plot of numbers that can give you a better appreciation for the probability. We deal with probability a lot, and toxicity is definitely a probability. So we try to minimize that, but I like the way that they present the tolerances. They give you the tolerances in a way that allows the clinician to make a decision about what they'll allow. So qualitatively, there's different ways to treat, and it depends on your technology, how you're going to treat. VMAT is becoming the standard. Most machines, all new machines are capable of delivering VMAT treatments. That doesn't mean that IMRT is not perfectly good, or that you can't get a worthwhile plan with 3D. After all, we started with this, and we got good cure rates with that, and we grew on it. Dynamic conformal arc is also something that was done previously and has kind of seen a resurgence. And I'll touch on dynamic conformal arc a little bit, but I think it's important to have in your arsenal, because if you have a nice spherical target and you don't need a complex dose distribution, you don't need to add the complexity of VMAT. You can have a much less complex plan, an easier plan to deliver with fewer moving parts, fewer moving leaves. So there's less of an opportunity for error. I think reducing complexity or making it as simple as possible, there's value in that. So not everything needs to be the fancy VMAT, but VMAT is a very, very powerful tool. So this is kind of, as SBRTs evolved, we realized early on that non-coplanar beams with couch kicks, could deliver the quote unquote best dose distributions. And you could get good with coplanar, but eventually I think what we discovered was that the trade-off with couch kicks and the dangers with collisions were not worth that. So from the most part, we're doing VMAT, and a lot of people are doing coplanar IMRT, where the beams are not opposed, but they're all in the same plane. when I started SBRT, we were doing 10 fields with couch kicks, and we were getting clinically acceptable plans. Now we do a VMAT, and it goes much quicker. And I think that the delivery time is something that's key too. So less patient motion, less chance for a collision. It has improved. So there are some things you can do in planning to improve the quality of your plan. That we're working on more optimization models that will do this for you automatically. But when we were doing 3D planning, you know, how you set that block margin was critical. You could get you could spike the dose by having a tighter block margin. You might even do an inverse block margin, where the block was actually going into the target. But collimator optimization, how you shift your collimator, and again, this is automatic in some newer planning systems that you can do the collimator optimization. But how you shift that collimator will change how the MLCs feed into the tumor and give you more conformal plans. So you can improve your conformity by changing your collimator angle. Again, the leaves, or technology, I should say, you know, everybody wants the greatest, but that doesn't mean that it's always necessary. So there's been a push. There was a push for a while to smaller and smaller leaves, and with the micro MLCs or the HD MLCs, which were 2.5 millimeter leaf width, and it does improve your conformity, but with modulation, a 1 centimeter width leaf, like from an Electa, can give you a comparable plan. Again, you're going to get you might be able to get a more conformal plan with those smaller leaves, but that doesn't mean that you're going to get an inferior plan, or a plan that's not going to be just as good clinically, and your outcomes are going to be inferior. So for the modulated plans, and this is for VMAT, especially with lung, you know, there is a concern of the interplay effect, whereby you've got a moving target and you've got moving leaves, and it's possible for those leaves to occlude the target or block the target. What's been shown is that if you have 2 full arcs, it'll wash out, even with stereotactic. There's a paper by Court out of MD Anderson, and they looked at how this would wash out over time, and 2 full arcs will eliminate the concern of the interplay effect. However, you can eliminate the concern of the interplay effect by just having an open aperture for the target for the entire time with dynamic conformal arc. So you could reduce that 2 arcs down to 1 arc. So it's possible for you to minimize that complexity. And I think that complexity should be minimized when it can. So the rotational techniques, the VMAT or arc therapy, it's very important, especially with couch kicks, that you work to avoid collision. More and more systems and software are working to have models of the linear accelerator. Unfortunately, they don't always have the patient. We don't do full body scans for every patient. If we did, it would bog down the planning system. It would be too much information. So we only have a piece of their body, and so that there's missing information that we may need to assess whether or not there's going to be a collision. And a lot of this can be, there are tables that you can use to essentially avoidance areas to avoid or angles to avoid. But with whenever someone's introducing a new technology, there's still going to be a learning curve. And so doing dry runs with, you know, either with a phantom, but just verifying that those table points or those table angles are very helpful. And I just certainly remember our center, when we first started, we had to do dry runs every time. And every once in a while, we would go back to the symmetry and say, we can't do this angle. And it was only with time that we learned what we needed to avoid. And it's also important that, you know, VMAT, you might not be able to get what you want. That maybe the patient has their arms down and you don't want to treat through their arms. So you can do an avoidance, or maybe they have a lateral or a highly lateral tumor, so you can't do an arc. You have to bring it back up, and maybe it's better to do a static IMRT plan. But IMRT is still a valuable tool, and it shouldn't be forgotten. So the 3D and IMRT plans, can range from 7 to 10 beams, and with the spine, they were originally recommended to do those with IMRT. VMAT has improved the optimization, and people have gotten better results with VMAT for the spinal cord. But sometimes, and maybe if you're still just learning VMAT, you know, working with the IMRT plans or the recipes that they have from Cleveland Clinic, those can be helpful. And now this is just again about the uncertainties, or I mentioned uncertainties before. This picture is a very frequently seen picture in stereotactic literature. And this is when people were just first starting out. They had, this was an example of you know, what can happen with some low dose spillage or the 50% isodose line reaching towards the skin, that you can have serious consequences. And what I've got down here is a paper where they looked at the inclusion of the mobilization device. So in Eclipse, you only calculate what your external is. You can add the couch, but it'll use that couch to reduce the intensity, but it's not going to calculate outside of the external volume, this green isodose line. This is using the Civco body ProLock, which is a table or a board, a rather thick board. So here they start to include it, and you can see that the isodose lines, the buildup is increasing. So the isodose lines are moving closer to the surface, and if you include the vac bag, again, it shows more. So you don't see what you don't look for. And I'm not advocating that you contour the vac bag every time, but it may result in a difference. And in this paper, they're saying it's easily 3% that you can gain by getting that information from contouring the vac bag. What I'm more advocating is that you won't see what you don't look for, and it's important to take into consideration things like this. If you had a posterior tumor, realizing that, you know, you're not going to see outside of the bounds you set. So it's important to keep these kind of things into consideration. Also realizing that what we calculate at the surface is uncertain, and it could be uncertain by as much as 10%. And maybe we're 10% low, but maybe we're 10% high. And so it's important to be careful in those areas where there's some uncertainty. And so just being aware of what you don't know is important. So that was kind of all the qualitative aspects, or those were some qualitative aspects of treatment planning quality control, or treatment planning quality assurance. So I'm gonna get into some of the quantitative aspects, but I'm gonna transition there through a discussion of philosophy. So there's different philosophies to quality control, or there's different methods of quality control. And a hybrid approach, a blending of philosophies is ideal. Previously, we used to be almost exclusively retrospective. We would look at the mistakes we've made, and then we would introduce new controls to ensure that they wouldn't happen again. But kind of a new paradigm it's not new in the sense that it's been around for a long time, but it's catching hold in medical physics. I think AAPM TG100 was actually a really big deal, and it's not fun to read. It's kind of boring, and some people think maybe it's obvious, but it's very helpful. It's a prospective way to look at quality control rather than looking back. It's looking forward. So the biggest thing is looking at your process flow, creating a process map, and then the failure mode and effects analysis, the FMEA. You go through your process flow, you look at the chain of events that lead to the treatment, and you look for weak areas and you focus your effort. We have a limited amount of time. We all have 24 hours in a day, and how we spend that time is up to us. But we want to use it in the way that's most effective, and the way that we can use it or the way we can pinpoint where it's most effective is by taking a step back and looking at the big picture, and then dialing in the important parts. This is from a paper. Also, Seifel Huck, who's been pretty amazing in his body of work over the years, where they looked at the process for a couple of centers in Brazil. They looked at 3 different centers in Brazil and how their stereotactic radiosurgery treatment flow was. And this is going to be different for almost every center. That doesn't mean that you can't use these published models as starting points. In fact, they're great starting points. But you may want to do it with a clean slate, with fresh eyes, without any kind of prompting. But in this case that they showed, they have the consult, the selection of the imaging protocol, the scheduling of the imaging, the nurse consultation in this particular flow, the imaging, the initial treatment planning, the target delineation, and they're identifying this as something that's very important and a failure point or possible failure point. And we'll touch on that later. Again, position and mobilization, the additional imaging, the more delineation, target delineation, the planning, the review, the QA, the accelerator QA, daily treatment. There's a whole chain of events that occurs, and looking at this before you treat is going to be a lot more helpful than looking back after mistakes happened. And that retrospective model is kind of how we've been looking at things for a long time. And one of the things, when an event does occur, you do a root cause analysis, you dig through, you figure out why it happened. You don't just settle for the simple answer, but you dig in. They say the 5 whys. We missed the target. Why did we miss the target? Well, the imaging wasn't aligned. Why wasn't the imaging aligned? Well, the isocenter wasn't in coincidence. Why wasn't the isocenter in coincidence? Well, the Winston Lutz passed, but or something. You've got to dig in to more than just the surface. And then the corrective action, and this is kind of what's been happening for a long time, is new controls. So we'll add another test. So that doesn't happen again. And we'll add another test, and we'll add another test. And sometimes we keep those tests indefinitely without looking back at why it was there originally added. So having this perspective view will help you identify which controls are actually the most beneficial. So again, moving into the quantitative aspects of quality control. The statistical process control, it was developed by Schuhart while he was at Bell Laboratories, and it was popularized by Deming, who is known for quality processes. But Schuhart, what he did is he was an industrial engineer. He was also he was a statistician, physicist, and mathematician. But he recognized that we had to look at things over a period of time to define action limits, and then to when to make it an adjustment and or when to investigate further. So looking at the normal variability, which, you know, everything is, there's going to be variation in your measurements, there's going to be variations in the machine, there's going to be lots of variations, and a lot of them are acceptable. But every once in a while, it's going to be necessary to investigate further. And applying this to treatment planning, we're going to look at metrics. Those metrics or indices, heterogeneity, conformity, gradient index, these are all common ones, and there's whole families of them. There are a lot of different names. But you won't know when you're out here unless you're looking at what you're doing over time, and you're looking at the different cases over time. So statistical process control is a very useful tool. And this is Deming who really popularized this method of quality control. He said, without data, you're just another person with an opinion. So we can make all the statements we want to make, but if we don't have data to back it up, we're just talking. And so here's an example of the use of metrics. So and how they can improve the quality of planning. So this is from Albert Einstein, the medical college or the medical school in New York City. They looked at before and after they created objectives and that people were to use. So before they used the planning objectives, and the orange, you can see that they were highly variability. There is high variability. After they created the metrics and they started tracking the metrics, you can see that they got much better conformity, and they just improved the consistency of their planning. Because if you don't have a benchmark or you don't have an objective, you know, you're going to look at the plan of the moment and say, okay, that looks good, without knowing that, oh, it looks good, but it could be better in these areas. And so it's important to look at those areas where you can improve. So the take home about that is, you know, the process control is important. You know, describe your planning objectives on paper, and ideally you want them to be quantifiable. And this is what, you know, Deming really hyped and really got going. But again, it was Schuhart that it's interesting. We forget about the original people. And then we remember the people that popularized things. So this sometimes is called the Deming cycle. But this plan, do, check, act, it's a continuous quality improvement. The idea is that your quality assurance, your quality management, it's not a one and done thing. It's not I did this and this is what I'm doing and I'm just going to keep doing it. You've got to track these things over time and see where you can improve. And if you continue to track these things, you're gonna always be able to get a little bit better. So, well, why quality? And this is the important thing: is it improves outcomes. If you focus on quality, you are going to improve your patient outcomes. And this has been shown. This right here is from Peters et al. In 2010, where this was with head and neck patients from QARC, the Quality Assurance Review Center. This is a U.S. Center for Clinical Trials. They looked at when this yellow is the plan was compliant at the outset. This is radiotherapy plans. It was compliant at the outset. It met protocol requirements. The blue one, it was made compliant. They sent it in and it didn't pass all what it was supposed to be. So they sent it back and said, well, we'll improve it in this ways. So they made it compliant. The gray one, it was not compliant, but they didn't predict a major outcome, call it a minor deviation. And then the red, it was not compliant at all, call it a major deviation. You can see very clearly that the adherence to the quality standards, it actually made a difference in patient survival and outcomes. And I think that that's a strong message that should be taken heed of. And there's also another meta-analysis of 8 different trials, and it showed the same thing. It showed that the adherence to the standards helped ensure better outcomes. And there's always more than meets the eye, and I want to acknowledge that. We don't know why these ones weren't compliant, and you know, maybe that's also why their survival was lower. But I think that the general take-home message, it has the ring of truth. So you apply standards, and you will get better outcomes.
And Peter, on that slide, I just want to make a comment. So if you look at the difference between the yellow line and the gray line, at 2 years, that's almost a 10 or 15% difference in survival. And that amount of difference is similar to like the benefit that chemotherapy has. So, you know, we think a lot about, oh, what are we doing? Are we giving our patient the best treatment? Oh, you know, we have to pay thousands of dollars to give them this chemotherapy, and that's expensive and toxicities, but we can achieve, you know, just as powerful gains just by doing what we do really well. And so, yeah, I think what you're saying is exactly right, that we shouldn't underestimate the impact of these small things that we do, especially in radiation, when we don't get immediate feedback. We can't tell, you know, in the first month whether or not that made a difference, but we do know years later that the graphs start to split.
Yeah. And I think that's important, that you see that it's tight. There's that tight grouping early on, and then later on you see the difference, and it's yeah. Thank you, Ben. I appreciate you hammering that home. It's because it's true. The quality improves the outcomes. So now we're going to talk about the metrics. So the numbers, and you know, physicists, we love numbers. Here's a couple of families, I should say. They're not, because there's a lot of different ways to measure these things, and it's very important that you pay attention to what you're looking at in the literature and how they're measuring it. And my big recommendation is going to be that you create your own metrics. That doesn't mean that you have to create your own wheel, but you have to adopt your own metrics and be very clear about what it is that you're measuring, and track your adherence to those metrics over time, and try to improve. So conformity, this is kind of the big thing in radiation therapy. We're trying to deliver energy to a specific volume. When we spill outside of that volume, you know, we want to be able to quantify that. So the conformity index does it in different ways, tries to quantify, you know, energy in the target volume. And there's the gradient index, which is the measure of fall off. You know, you've got an isodose surface at a point, and then you've got another isodose surface, and measuring that fall off, or that distance, is the gradient index. And then the heterogeneity index in stereotactic, it's not always seen as so important, but I think it is important, at least to be aware of it, and also to assign realistic limits, and just to be aware of your hot spot inside your tumor. You know, and that's pretty much what the heterogeneity is it's just a measure of the hot spot inside your tumor. So the conformity index, there's a lot of different conformity indices. A lot of people have tried to define these in different ways. The RTOG has a very simple definition, and I've got a bigger equation of that on the next slide, so we won't dig into it. but this is just to show that there are different indices, and they'll give you different results. So you can actually get a perfect RTOG for a complete mismatch. And that's why the Van Riet or the Paddick has been adopted. But the big challenge with the conformity indices is the fact that in stereotactic, the volumes are really small, and we'll talk about that further. But measurement of the conformity is important, and it's important how you choose to measure it. So I would say the most common, or the original method, is the RTOG Conformity Index, and that's the volume of the 100% divided by the treatment volume. So ideally, you're looking for a value of 1, where your treatment volume, let's call it the treatment volumes, we'll say that's the shaded area, and then the volume irradiated with the prescription isodose line are completely overlapping. But the big critique about the RTOG is that it didn't have any spatial information. So you could get a perfect conformity index with completely mismatched or misaligned volumes. It just didn't give you any information about where that dose was going. So Van Riet, and I want to give Van Riet credits. This goes back to the Schuhart. There's always somebody that came up with this idea even before. It's kind of funny. We forget about these things, but it's nice to give a shout out. So Van Riet first gave this conformity in 97, where he penalized dose outside of the target volume. So you would get a different value. You're still going for an optimal of 1, but you could get a lower number if you've got too much spillage, or you're not completely covering the target volume. So this is commonly known as the Paddick Conformity Index, and the simple reason for that, Paddick did a good job of explaining it, but he also published his work in a radiosurgery journal or a neurosurgery journal. So he published it in the context of stereotactic, and it's got his name for a lot of people. So the Paddick Conformity Index, again, it's the same as the Van Riet, but it penalizes the prescription. It penalizes when the prescription isodose line, your 100% volume, or your 100% either falls out or doesn't encompass your target. So it's important to note that none of these metrics are perfect, and so you just got to use them with some awareness of what you're looking at, and also focus on the actual picture of the isodose lines. So don't just take a number, but look at it in the clinical context, because you can get identical scores with varying clinical significance. So here you've got a conformity index of 0.5, in which the target or the tumor is completely encompassed by the prescription isodose line, and that might be acceptable, even though it's a low conformity. Here you also have the same conformity of 0.5 on the number 4. I'm hoping you guys can see my cursor, where you see that the prescription isodose line, it's the same volume, it's the same size, but it's offset, it's missing the target. And the RTOG gave that a perfect score of 1, but this is clearly an inferior plan, or an inferior plan. So using these numbers, they're helpful tools, but you've got to keep your eyes open with them and realize that different ways of calculating them will give you different numbers that will have different clinical significance. So the gradient indices, this is a measure of the drop-off. There's the way that the RTOG is very common, is the 50% divided by the 100% volume. And this is a very common method. The one that I really like is from Wagner et al., and it uses a spherical approximation. And I'll show how that works. But it gives you a distance. It essentially it approximates the two volumes as a sphere, and then gives you the distance between the 50% and the 100%. So it gives you a good idea of fall off. So the volume of a sphere, 4/3 over pi r cubed. And this is a cool little Kickstarter. It's like a glass sphere with a picture of the universe. So you approximate the sphere based on the known volume. You can know the volume of your target, or of your 100% isodose line. You know that so you approximate that as a sphere. Then you approximate your 50% isodose line as a sphere, and then the two radiuses gives you that distance of that fall off. And I really like the fact that it gives you a value that you can appreciate in terms of millimeters. So you can seek to achieve a 5 millimeter fall off. Maybe you can't get 5, you get 7 though, or you can feel good about how tight and how close that gradient is, just because of to me, it's actually a physical number. It's a distance rather than just a ratio. So the other one, the heterogeneity index, is the ratio of the maximum dose to the prescription dose. This is one of the original RTOG values for SRS. It's also an important thing to pay attention to. It's just your hotspot. And it may be desirable to have a hotspot within the target. I think common for LINAC-based programs to limit it to 1.3. And I'm going to show why that a lot of people do that at 1.3. And this again goes back to why you should track your numbers, because if you don't look, you won't know. But this Hong et al., they studied the relationship between the homogeneity, conformity, and gradient indices. And what they found was that the gradient index decreased. They could get a tighter gradients by increasing the hotspot, which makes sense. But it plateaus at about 1.3. You don't get any more benefit past that 1.3 value. It plateaus. So you don't, spiking it past 30%, 130%, you're not increasing the sharpness of the fall off. And the same with the conformity index. It also decreased with increasing hotspot. You got better conformity, but it approached a minimum at about 130%, or a gradient or a heterogeneity index of about 1.3. And without studying these things, you don't see these things. So that's why I'm a big proponent of at least recording these things and then taking a look back at what you've done. And I think that this was a pretty good study. So there are some other ways in which metrics vary. There's other dependencies. Volume is a very common one. So dose doesn't drop off as steeply with large volumes. So the larger your volume, you're not gonna get as good of a gradient. So this is fall off, measured gradient in percent by centimeter. So for these large volumes out here, they're saying you're getting more about 65% fall off per centimeter, versus up close, this smaller volumes, you're getting closer to 100% within a centimeter. So another one, the conformity suffers with smaller volumes. You should be able to get a highly conformal plan with larger volumes, but as you get into the smaller volumes, down into the very, very small radiuses, you're going to get much less conformity. And the RTOG, with their guidelines, and this is from 813, they recognize that. And so this table, which is very commonly adopted, it actually accounts for that the fact that you're not going to get as sharp fall off, or you might have a higher max dose with volume. So that's why they don't just have, well, I guess they do for the conformity, which is interesting. They have just these set as a number, but for the fall off and the hotspot, they respect the fact that you're going to get different values for different sizes. So stratifying by volume is important. It's also been shown that you can maintain your target coverage independent of your conformity, where your conformity is going to suffer for the smaller volumes. It's much harder to have a very sharp fall off and a very conformal target for something very small, especially depending on your leaf width, but you can still maintain that target coverage. So just focusing on the index alone may be misleading. These are very helpful tools, and I don't want to ever, take away from that. I want that to be driven home that these are very helpful tools, but they need to be used with your eyes open and used with clinical judgment. So in studying these things, different conclusions have been drawn, and it's important to kind of look at the whole picture. Again, not just looking at the conformity index, but looking at the whole picture. In this study, an older study, they found a strong positive correlation between conformity and complications. So the more conformal the plan, the more complications. But it's very obvious that the conformity was actually correlating with the volume, and so the complications were actually due to the volume, not necessarily the conformity. So just looking at the big picture with these numbers and realizing that they're helpful, they're part of how we make our decisions. And this is another study where they looked at conformity, and they made some conclusions. And this is actually in the UCSF handbook on stereotactic, which is interesting. It used to be a handbook that would fit in a lab coat, and it's gotten thicker and thicker. It's amazing. But this is a study out of Stanford, where they evaluated local control as a function of conformity for resection cavities. And what they did is they used that spherical approximation that where you use the volumes to create spheres. And they found that with reduced conformity, and they correlated this to a margin, you would get better control rates. So what they did from this paper is they recommended a 2 millimeter margin for resections and 1 millimeter margin for intact metastasis. And it's interesting. It was a very clever study, and it's had an impact because I think a lot of people use these margins for their resection cavities. And it's by tracking the data that they can look back at it and make these clinical recommendations. And I think it's important that this is taken into context. This is not, once this paper was written, that's not the end of it. You've got to be able to update your knowledge. And there's been new studies, this one from Emory, where they looked at the PTB margin for resected brain metastasis. It's kind of the same thing that Soltis looked at. But they didn't find a benefit in increasing the margin beyond 1 millimeter. In fact, they found that with the margin increased beyond 1 millimeter, they had more complications. And they also acknowledged the volume effects in terms of the rates of recurrence and toxicity. So their recommendation is now 1 millimeter. And I'm not proposing that you adopt either of those, but being aware of them, and also, collecting your own data so that you can make your own clinical judgment with time, or figure out what's right for your center. Because just updating knowledge is important. The NHS, they dug through a retrospective study of all their patients, or a large number of their patients for SBRT. And they looked at them relative to RTOG recommendations and the Rosell recommendations. And they even added some new metrics. They did this prescription dose spillage and this modified gradient index, and they correlated these with quality. And I'm not recommending you adopt these either, but be aware of them and how they measured the quality for their patients and how they publish the outcomes, and then kind of make an informed decision about how you would want to track your quality, how you would want to focus on improving your treatment planning. And again, it's a personalized approach to some degree, because there's a lot of different equipment out there. There's a lot of different MLCs. There's a lot of people are using dynamic conformal arcs. People are using VMAT. So knowing how your system performs and what you can best deliver for your patients is important. And we don't know unless we look. And that was that Albert Einstein study from the Albert Einstein School, where they had it before they started tracking their metrics. Their numbers were all over the place. Afterwards, they had a tight banding. Once they started measuring it, they were able to maintain a consistent level of quality. And then, because if you don't have that consistent level of quality, you won't know what you've done right over time with these patients. And monitoring it is really important. And it's important that you monitor it relative to your technology. You can see there's a difference here. Their dynamic conformal arc versus their VMAT, there's some clear banding. So knowing what you can achieve with your technology is important. So stratifying your values. And I can't stress enough to keep your eyes open. I think that this is very important. And these are two great books. I'm a big person into data. I love data. I really like machine learning and artificial intelligence and where we're going in society. But I think it's important that we have our eyes open, because these metrics are what's driving optimization, are what's driving, and it's not just these radiotherapy metrics, but there's all kinds of different metrics that are applied all over the place. If we're not clear on the metrics, if we just treat things like a black box, they can get out of control. Because there's definitely going to be situations where an inferior index or an inferior metrics will yield a superior plan for the patient. And there's really no substitute for clinical judgment. There's people aren't being replaced yet, or hopefully, there's always going to be a place for us, because you can look at all these plans, and maybe the metrics are saying that this looks like a good plan. The metrics are saying like this looks like a good plan, but this is clearly missing some of the target. So even though this has got inferior metrics, maybe that's and clinically that's probably what's going to be adopted. This is the one that's going to give the best outcome for the patient. So there's no substitute for clinical judgment. Be aware of your metrics, but use them, but don't use them with your eyes closed. Use them with your eyes open. And know your uncertainty. This is the big one. This is only one of many studies that were done in this case. In this case, they performed a contouring study in which 8 physicians each contoured 14 metastases. So this is the up top are the DVHs for the reference contours, quote unquote. And then this is for the different contours that were drawn. So you could get wildly disparate results based on how you draw something. And it's not just, there's not just inter-user variability or inter-observer variability, there's intra-user variability. If you draw something in the morning versus in the evening versus before lunch or after lunch, there's going to be variability. So the biggest thing for quality assurance is peer review. That's the #1 quality assurance tool. It's a second check for everything. And that includes targets. And it's It's hard to do in a busy clinical setting, but it's really valuable. And if you can do it, you can see here that these were drawn many different ways. It's going to lead to better outcomes and better quality. I'm going to touch on this today. I'll dig deeper on Thursday, because this is kind of an imaging thing. But beyond the uncertainties in the contouring, there's uncertainties based off of your slice thickness and your calculation grid. So your grid for dose calculation should ideally be matched with your voxel size for your imaging, but you can get different metrics. You can get different values based on the calculation grid. And again, I'll touch on this more on Thursday. But knowing your uncertainties in the contouring and your calculation is very important. So to conclude, quality metrics are invaluable tools, and they allow you to quantify the differences between planes. They're very helpful for quality assurance, especially quality assurance over time. But they all have to be used in light of the big picture. Each of the metrics are just another little thought point, another little idea to help you with the overall big picture and the treatment decision. But tracking your values over time, this is for IGRT, so we'll touch on it on Thursday. Tracking your things over time, you can find when you need to address something, when something might lead to an error. So this is my final conclusion page. It's 2 of them. So there are many ways to measure plane quality. The essential element is that you look and apply what makes sense to your clinical team. Record what you achieve with your combination and always seek to improve. It's a continuous cycle, and we're always getting better, but we don't get better if we don't look. So thank you. That's it.
Wow. Thank you very much, Peter. That was a very in-depth look at these metrics for plan evaluation. I really appreciate how well you went over the different metrics for SRS, specifically the conforming and Conformity Index, Conformity Gradient, the Heterogeneity Gradient. That was really interesting. I actually have a question about TG 100.
Mm-hmm.
Have you yourself specifically done any of these failure mode analyses?
Yeah, we did a failure modes and effects analysis for our stereotechnic program in Cincinnati. And it was a useful tool. It helped us kind of identify areas. Like one of the areas that I think is not always recognized because it's not always part of the physics domain, but is the nursing consult and actually collection of the prior data. That was a big one. But we presented a poster on that at a local chapter meeting. And they're also really helpful for just facilitating team cohesion. You get the group together. You should have different players from different areas, but you're going to improve communication. And anything you can do to improve communication in an organization is going to improve your quality. So I think that they're good exercises, even if beyond the quality improvement for team building. I think that they're really helpful.
Interesting. Okay, we're gonna open the floor for any final questions from those that are participating. If you want to turn on your microphone, you can. Si alguien quiere prender su micrófono para hacer una pregunta, Dr. Sandwall está abierto a tiempo. We'll wait a few minutes, see if anyone asks any questions. También las preguntas se pueden hacer en la cajita del chat, como ha puesto Ben.
And maybe while people are thinking, I also wanted to give a little applause for an excellent presentation. I think this is a great resource and overview of some things that we've seen sort of thrown here and there, but this was the first time that someone told me, hey, the conformality index can be a bunch of different ways. Because every time I saw it a different way, I would get confused. And I was like, wait, I thought I just learned it. Now this is something different. So it's good to know. It's good to know that.
Absolutely. Yeah, I'm glad you liked it. Yeah, the metrics, I like them. I think they're fun.
You personally, Dr. Sandwall, which ones do you focus on? Or you do focus on all of them?
I like the Paddick, but the Paddick in light of RTOG. So both the RTOG and the Paddick. I really like the gradient index that does the spherical approximation. That's my favorite. I do them both though, the RTOG and the spherical approximation, and then the heterogeneity. So those are kind of my five. I do 2 conformity, 2 gradient, and then the 1 heterogeneity.
I like that you like the gradient index. That came out of my lab, the University of Florida.
Oh, nice. Yeah.
And also,
go ahead.
I know on this call we have not just medical physicists, but also radiation oncologists and also medical technologists. And, we really all are part of the one team. And, I found this talk very helpful to know what are the details of it that my colleague will be focusing on. And I think it helps me understand my role better. And from a radiation oncologist, I think this will give me a better sense of how I can think about determining if something is a good plan or not. I think it'll help with my plan evaluation skills.
Excellent.
I think we'll be able to wrap this session up, I believe.
All right. Thank you very much. I appreciate the opportunity to share. I hope you all enjoyed it, and I see a lot of names. Hopefully we cross paths in the future.
Excellent.
Thank you very much, Dr. Sandwall. This is a very informative session. We're also excited for the next one that will be this Thursday at the same time.
Mm-hmm.
Excellent.
Okay.
Thank you.
We'll share the slides. Thank you.
All right. Okay. Bye-bye.
Buenas noches a todos.
Y vamos a concluir esta sesión. Estamos agradecidos por el tiempo que nos dio Dr. Sandwall. Y él nos va a dar la próxima sesión otra vez este jueves al mismo tiempo. Entonces, con eso vamos a concluir. Muchas gracias. Buenas noches a todos ustedes.